Suctioning of the pharynx is indicated to maintain a patent airway and remove saliva, pulmonary secretions, blood, vomitus, or foreign material from the pharynx. It helps a patient who can successfully clear his airway by coughing and expectorating. Equipments used: portable or wall suction unit with tubing, an appropriate sterile suction catheter, sterile water or saline, towel or waterproof pad, goggles and mask or face shield, disposable clean gloves, water-soluble lubricant, sterile gloves. Assessment: assess lung sounds. Patient who need to be suctioned may have wheezes, crackles, or rhonchi present.
In performing suctioning, we first identify the patient. Positive identification of the patient is essential to ensure the intervention is administered to the correct patient. Next, we determine the need for suctioning. We verify the suction order in the patient's chart if necessary. For post-operative patient, administer pain medication before suctioning. This is to minimize trauma to airway mucosa. Suctioning should be done only when secretions have accumulated or adventitious breath sounds are audible. Perform hand hygiene. Hand hygiene deters the spread of microorganisms. In performing hand hygiene, we first wet our hands. Then we apply soap or we apply betadine to our hands. Then we lather, rinse, and then repeat. For sterile hand washing, we scrub first our fingers, in between our fingers, the palms of our hands, the back of our hands, and then we extend till 1 inch above the elbow. Then we do the same with the other hand. This will promote killing of the microorganisms from the palms of our hands to the 1 inch above the elbow. This is the proper sterile technique. But in the sterile technique, we use brushes that are provided by the hospital. Adjust the bed to a comfortable working position. Lower side rail closer to you. Place towel or waterproof pad across patient's chest. This protects the bed linens. Adjust suction to appropriate pressure. Higher pressures can cause excessive trauma, hypoxemia, and atelectasis. For a wall unit for an adult, 100 to 150 mm mercury. For neonates, 60 to 80 mm mercury. For infants, 80 to 100 mm mercury. For children, 100 to 120 mm mercury. Open sterile suction package using aseptic technique. The open wrapper or container becomes a sterile field to hold other supplies. Carefully remove the sterile container, put on sterile gloves. The dominant hand will manipulate the catheter and must remain sterile. The non-dominant hand is considered clean rather than sterile and will control the suction valve on the catheter. Handling the sterile catheter using the sterile gloves help prevent introducing organisms to the respiratory tract. The clean glove protects the nurse from microorganisms. With dominant gloved hand, pick up sterile catheter. Pick up the connecting tubing with the non-dominant hand and connect the tubing with the suction catheter. Sterility of the suction catheter is maintained. Moisten the catheter by dipping it into the container of sterile saline. Occlude the white tube to check suction. Lubricating the inside of the catheter with saline helps move secretions in the catheter. Encourage the patient to take several deep breaths. Suctioning removes air from the patient's airway and can cause hypoxemia. Hyperventilation can help prevent suction-induced hypoxemia. Then, apply lubricant to the first 2 to 3 inches of the catheter using the lubricant that was placed on the sterile field. For oropharyngeal suctioning, insert the catheter through the mouth along the side of the mouth toward the trachea. Advance the catheter 3 to 4 inches to reach the pharynx. Apply suction by intermittently occluding the Y port on the catheter with the thumb of your non-dominant hand and gently rotate the catheter as it is being withdrawn. Do not suction for more than 10 to 15 seconds at a time. Turning the catheter as it is being withdrawn minimizes trauma to the mucosa. Turn off suction. When suctioning is completed, remove the gloves from dominant hand over the coiled catheter. Pulling it off inside out, remove glove from non-dominant hand and dispose of gloves, catheter, and container with solution in appropriate receptacle. Then, reassess the patient's respiratory status, including respiratory rate, effort, oxygen saturation, and lung sounds. This assesses effectiveness of suctioning and the presence of complications.
Chest physiotherapy includes postural drainage, chest percussion, and vibration. Auscultate the chest before and after the procedure to identify the areas that need drainage and assess the effectiveness of the treatment. Perform chest physiotherapy in the morning on arising 1 hour before meals or 2 to 3 hours after meals to prevent nausea, vomiting, and aspiration. These are the following positions in postural drainage. Lower lobes, anterior basal segments. Lower lobes, lateral basal segments. Lower lobes, superior segments. Upper lobes, anterior segments. Upper lobes, apical segments. Upper lobes, posterior segments. Percuss the area for 1 to 2 minutes. Vibrate the same area while the client exhales 4 to 5 deep breaths. Monitor for respiratory tolerance to the procedure. Stop the procedure if cyanosis or exhaustion occurs. Maintain the position for 5 to 20 minutes after the procedure. Repeat in all necessary positions until the clients no longer expectorate mucus. Dispose of sputum properly. Provide mouth care after the procedure.
We're going to the Southwestern University College of Nursing because we do suctioning and chest physiotherapy procedure. What we're going to do? We demonstrate it! Yeah, bye-bye. See you!
Oppan Gangnam Style.
Yung katawan sa nasi wasak na ayam! Ano, oy?